In this video, we're going to talk about how to help somebody who's choking, and this will cover people of all ages who might be choking. So with somebody's choking, no matter their age, you always want to start by figuring out, is it a mild choking or a severe choking? With mild choking, they only have a partial airway obstruction. Most likely the patient's going to be coughing. They may even be able to talk to you. But if they're coughing and or talking, that means they're breathing. So we don't want to do anything to make the situation worse. You're going to encourage them to cough. If you have blow by oxygen, you can give them blow by oxygen. It's not a bad idea to get them something to vomit in because they are likely to throw up. And you're going to transport them. That's really all we can do. Anything that you do to try to relieve the item could possibly cause it to become more serious. If they're coughing and talking, that means they're breathing, and I'm happy. Breathing is a good thing. Now, a severe airway obstruction is different. This is a complete airway obstruction. They're not able to talk, they're not able to cough forcefully. You may hear a whistling sound as they try to breathe. That would be stridor, as that air is kind of moving around that item. If it sounds like they're breathing through a coffee stirrer and you hear this whistling sound, that's not enough air to support life. Or they may not be making any noise at all. Now, typically, somebody with a severe airway obstruction or a complete airway obstruction, they're going to be holding their throat. That's the universal sign for choking, and they're not able to talk to you at all, but they need intervention. We need to do something to help remove that item. Now, this is going to vary by their age as to what we do next. Anybody who's over age 1, we're going to do the same thing. So children and adults, we do the same thing, and that is abdominal thrusts. Now, people used to call this the Heimlich maneuver. It's still the same thing. It just has a different name. It's called an abdominal thrust. And we're going to do these abdominal thrusts until either the item comes out or until the patient loses consciousness. So if the item comes out, great. You still may want to transport them just to check to see if they've injured their throat in any way. But if they lose consciousness, we're gonna go into CPR. We'll talk more about that. Okay. So for those abdominal thrusts, those are going to be between the belly button and the ribs. What you're doing is you're trying to push the diaphragm up to dislodge the item. So the diaphragm is the muscle that we use for breathing. It's a horizontal muscle and it separates the thoracic cavity from the abdominal cavity. When we inhale or breathe in, we pull it down to pull more air into our lungs. And when we exhale or breathe out, we push it up. We really just relax and it pushes itself up to force air out of our lungs to exhale. So when somebody has a severe choking emergency, we want to try to manually push that diaphragm up to force air out of their lungs in hopes that that air coming out of the lungs will dislodge the item that's in the way. So to do this, you're going to have your hand in a fist. You have your other hand on top of it, and you're going to place your fist between the belly button and the bottom of the rib cage, just usually an inch or two above the belly button. And you're going to do this like the letter J. You're pushing in and up, in and up, in and up. And you're trying to push into their abdomen, up under that diaphragm, and push that diaphragm up. So it's like the letter J. And you want every single one of these to be as forceful as you possibly can. If you start, you don't want to hurt them and you start kind of gentle and you do the first one and the second one and the third one, and you get to about the fifth one and you finally panic and go as hard as you can. Well, you've already squeezed a lot of the air out of the lungs. And so now there's not as much air left to try to push the item with it. So you want every single abdominal thrust to be as forceful as you can possibly do it. Now, to accomplish this, for these to be forceful, I mean, we're trying to knock the air out of somebody. If they're your height or taller, it's quite difficult to get your arms around them and have very much strength to do that J motion. So if they're your height or taller, I would recommend have them kneel in front of you. And that way you can kind of hook underneath them and you're going to have a lot more strength standing above them doing those abdominal thrusts. Now, for an infant, it's slightly different. Again, if they're still coughing, we're just going to let them cough. There's really not much we can do. But once they're unable to make any noise, instead of the abdominal thrusts, we actually do 5 back slaps followed by 5 chest thrusts. And just like the adult and the child, we do this until the item comes out or they go unconscious. Now, when you're doing these back slaps and these chest thrusts, you're basically trying to knock the air out of them. So they need to be pretty forceful. The back slaps are going to go right between the shoulder blades. The chest thrusts are the same location as where you do CPR. You're just like chest compressions. So I actually have a video of this. So let's have a look at what these back slaps and chest thrusts look like.
For an infant who's choking, but they're still conscious, so they're not making any noise, it's a complete airway obstruction or severe choking, but they're still fully conscious, we want to do back slaps and chest thrusts. To get the infant in position for those back slaps, you're going to have them straddle your arm, use your hand in a V across their chin. What this is going to do is support the weight of their head and support their neck. As we know, infants often are not able to support their own head. So this is going to support their head, but notice I'm in a V. The mouth is not covered. If I put my fingers over the mouth, if the item comes out, I may push it back in. So I'm going to go V across the chin. Now I'm going to angle them down so gravity will help me. For these back slaps, I'm going to go right in the middle of the shoulder blades, 5 good hard slaps. I'm trying to essentially knock the air out of them. So I have head facing down, 1, 2, 3, 4, 5. Okay. After 5.
And by head facing down there, I mean really head angled down. So gravity will help push that item down out of the airway.
5 back slaps, I want to quickly flip them over and give 5 chest thrusts. Now to flip them over, I still need to support the back of their head. So I'm going to sandwich them between my arms, putting the back of my other hand on the back of their head to again support their neck. I'm going to flip them over. Again, gravity, head down so gravity will help. 2 fingers right in the middle, just below the nipple line, just like we did for chest compressions for CPR earlier. 5 compressions. 1, 2, 3, 4, 5. And then I'm going to, again, quickly flip them. Quickly flip them. And I'll continue to do this until either the item comes out or if they go limp in my arms, I know they've gone unconscious. And at that point, I will lay them down and I will begin CPR.
Okay. So that's how we do the abdominal thrusts on an adult and the back slaps and the chest thrusts on an infant. The other thing is if we do those back slaps and chest thrusts or those abdominal thrusts on an adult, eventually, if the item doesn't come out, the person's going to lose consciousness because their brain's not getting oxygen. So when they lose consciousness, support their head and neck, lay them to the ground, and begin CPR. Now, we just did a ton of videos on CPR, so I think you know how to do CPR by now, but there's a couple differences. Earlier, every time we did CPR before we started, remember, we checked pulse and breathing at the same time. Well, we already know this patient's not breathing. That's why we were doing either abdominal thrusts or chest thrusts and back slaps. So we know they're not breathing. So we're not going to waste any time to check for breathing. We're going to go straight into chest compressions. Those chest compressions may dislodge the object. So they may still have a pulse. I'm not going to take any time to check it because my chest compressions are not that different from my abdominal thrusts. So I'm going to do my chest compressions. After 30 chest compressions, the other thing that's different is before I give breaths, I'm going to actually look in the airway. So I'm going to open the airway, look in the mouth. Now, if I can see the item, I'll try to take my finger and scoop it out. If it's a baby, an infant, I might need to use my pinky to try to scoop the item out because their mouth is small. If I can't see the item, I do not want to put my fingers in their mouth because if it's near the top of the throat, I may push it further down into the trachea, lodging it even more or even more deeply. So if I can't see it, I am going to take my BVM and I am going to try to give 2 breaths. Now you might be thinking, well, Danielle, the BVM is going to push it down further too. You're right. It might, but it's kind of our goal here is our compressions might push it up. Our BVM might push it down. So we're trying to wiggle it back and forth to where we can eventually get it to come out. And if we couldn't see it in the mouth, maybe it's so far down that it's close to the lungs and our BVM may push it a little bit further and get it into the lungs. So that's different than putting our fingers in there because it might be close to the surface and we push it down. Whereas the BVM, it could be much further down and we could still force it down. One thing to take note of is a lot of BVMs have a very useful tool called a pop-off valve or a valve that regulates the pressure. And that is there as a safety so that when you ventilate your patient, you don't overinflate their lungs. Before you can overinflate their lungs, this pop-off valve will basically let air out of the valve instead of forcing it down into their lungs. Most of the time, that's a great safety mechanism for using a BVM. However, if somebody's choking and you're using that BVM on them, we want to be able to force as much pressure as we possibly can so that we can maybe push that item down into their lungs. So if it has a pop-off valve on your BVM, make sure it's closed. Infant BVMs and pediatric BVMs almost always have a pop-off valve. And with the adult BVMs, it's 50-50, maybe 25-75. They usually don't have them, but they might. So if it has a pop-off valve, make sure sometimes you twist it, sometimes it's just a little cap you push on or take off, but make sure it's closed so that air can't leak out of that valve. We want to push with as much pressure as possible. Okay. So that's the two big differences. We're not going to take time to check pulse and breathing. And every single time before you give breaths, you're going to look in the mouth. If you see the item, try to scoop it out. If you don't see the item, try to give the 2 breaths. Right back to 30 chest compressions, look in the mouth again. If you see it, scoop it out. If you don't, give the 2 breaths. Just over and over and over, each time before breaths, looking in the airway. One other change, typically if we're doing CPR and or using a BVM, we insert an OPA into the airway to hold the tongue out of the airway. You would not want to use an OPA or even an NPA in somebody who's choking. If that item starts to come back up and the OPA is there, it may push it back down further again. So don't put anything in the mouth. You may need to suction, but just be really careful and look what you're doing and make sure you're not pushing that item further down. One other thing I thought about while I was talking there, if you have a patient who is pregnant or morbidly obese, you may not be able to do those abdominal thrusts because you can't get up under the diaphragm. If you can't access the diaphragm, instead, you're going to put your arms around them, put your hand in a fist, but you're going to put it right in the middle of the chest, right where you do for CPR compressions, and you're going to push there instead of up under that diaphragm. That's just the best you can do. So when you lay that patient to the floor to start CPR if they're unconscious, that's almost the same thing, but you can be even more forceful. So that's what made me think of that. Okay. I think that's all I have for you for choking, and I'll see you in the next video. Thank you.